Welcome to this talk entitled Number Needed to Treat, Analyzing the Effect of Addiction Treatments, Explorations and Diversions. You might be wondering what number needed to treat means, and I'm going to come to that soon. First, we will look at this government report entitled Drug Treatment and Recovery by Dame Carol Black, published in 2021. Dame Carol Black was appointed to lead a review, and the report's aim was to make sure that vulnerable people with substance misuse problems get the support they need to recover. And I want to look at two statements from this report. First, it must be recognised that addiction is a chronic health condition, and like diabetes, hypertension, or rheumatoid arthritis, it will require long-term follow-up. Second, we recommend that the government invests an additional £552 million in the treatment system. The word treatment is mentioned over 200 times in the report, and one of the key points is the assumption that treatment for addiction is effective. Indeed, the report states that for every £1 spent on harm reduction and treatment, there is a combined health and justice return on investment of £4, and I will come back to this later. The report also says the vast majority of users do not see themselves as having a drug problem and are unlikely to come forward for treatment. The report also states that discharge after short-term treatment is currently used as a measure of success but should be stopped as it ignores the fundamental relapsing and remitting nature of the condition. It also says too many people are in and out of treatment for years or even decades without turning their lives around for good. Does this mean that in fact the treatment is not successful in breaking this cycle? And if not, why not? With that in mind, I would like to consider this quote from Ben Elton's book, Time and Time Again. Isaac Newton banged the table with his fist, upsetting his wine for the second time that afternoon. What do you mean, of course it does, he shouted. What sort of argument is that? You're a teacher, or so you claim to be. You must know that it is not enough simply to assert a point. You must make some demonstration, offer up some reasoning, some proof. One way of thinking about this is, what evidence do we need to evaluate treatments for addiction? At the most basic level, the question is whether there is a correlation between getting treatment and successful outcomes, however that is defined. However, in real life, we're often very poor at estimating these correlations because we generally pay too much attention to certain pieces of information and not enough to others. This is illustrated in the first table below, which has been called the Great Fourfold Table of Life. Let's look at this table, showing the relationship between whether there is a full moon and number of psychiatric hospital admissions. We can see in the table that there are 4 cells showing the presence and absence of a full moon and psychiatric admissions or not. What does this table tell us? We typically pay too much attention to cell A, that is, where there is a full moon and there are admissions to hospital, and not nearly enough to cell B, where there is a full moon but no hospital admissions. That's understandable because the A cell is usually more interesting and memorable than cell B. We also need to look at cells C and D where there is no full moon to get a comparison. Without this information, it is impossible to draw any conclusions about whether there is an association between full moon and hospital admissions. Looking at the lower table, we can see the same principles in relation to addiction. Here we have the presence or absence of treatment, and the outcomes can be getting better or no change. A key question is whether we have this sort of evidence in relation to addiction. Unfortunately, our minds are not good at detecting and remembering non-events, that is, things that don't happen. It's unlikely we're going to rush home excitedly to tell our friends, wow, you're not going to believe this. There was a full moon tonight and nothing happened. Our uneven attention to the different cells leads us to perceive illusory correlations. And this may also be true when it comes to interpreting the effectiveness of addiction treatments. So now we come to the concept I mentioned at the start of the presentation, number needed to treat, or NNT for short. The NNT offers a measurement of the impact of a medicine or therapy by estimating the number of patients that need to be treated in order to have an impact on one person. We know that not everyone is helped by a medicine or intervention. Some people will benefit, some are harmed, and some are unaffected. The NNT tells us how many of each. This last point is very important, and we will look at this in relation to the Black Report issued in 2021. So to expand on this, the number needed to treat tells us how many patients must receive a particular treatment for one additional patient to experience a favourable outcome, such as treatment response. But also important is the second point on this slide, the number needed to harm. This tells us how many patients must receive a particular treatment for one additional patient to experience a particular adverse outcome. So, for example, a drug may have an NNT of 3 for pain relief and an NNH for 50 for a blood disorder, meaning that for every 3 people treated, 1 will have pain relief, and for every 50 people treated, 1 will have a blood disorders. Lower NNTs and higher NNHs are associated with a more favourable treatment profile. If the NNT is smaller than the NNH, does this mean that the risk-benefit ratio is favourable? Not necessarily. Clinicians need to make a subjective judgment about the value of the benefit and the seriousness of the risk. In the example that I just mentioned, the blood disorder is far less likely to occur than pain relief. However, the potential seriousness of the disorder would certainly discourage the clinician from prescribing the drug. What about the number needed to treat and the number needed to harm for a commonly prescribed drug? In this slide, we look at people who take statins for 5 years. Statins are medication used to lower the level of cholesterol in the blood. They're one of the most prescribed drugs in the UK, with an estimated 7 to 8 million adults taking them. These data examine the effect of statins for people who have known heart disease or a history of stroke. The effectiveness of statins is fairly consistent across this group. They lower cholesterol in most people who take them. This slide shows the number needed to treat and the numbers needed to harm. In terms of the number needed to treat, we can see that 1 in 125 people were helped in terms of preventing stroke, 1 in 39 were helped in terms of preventing a non-fatal heart attack, and 1 in 83 people's life would be saved. In other words, this shows that there's a 1.2% lower chance of death, a 2.6% lower chance of heart attack, and a 0.8% lower chance of stroke. As a public health measure, this suggests that statins do have an identifiable effect, although the chances of any one individual being affected are small. 19 out of 20 people who take the drugs saw no effect. When 1 million people take these drugs, then roughly 45,000 people saw some benefit, while perhaps 6,000 see some harm. So yes, some people do benefit, but we don't know which ones. We can also see that some people would be harmed. Another writer says it may come as a shock that drugs shown in rigorous studies to be, quotes, effective actually help so few people. But there are sound medical reasons for that. For one thing, treatment is never perfect. Effective drugs may help a lot of people, but a lot is rarely everyone. So again, this is an important concept for us to consider when we think about addiction treatments. There is one other important point that we need to consider, and it is illustrated here in a study of antidepressants for pediatric patients. In this study, a meta-analysis of randomized control trials found that the number needed to treat was 9. In other words, if 9 depressed pediatric subjects are treated with an antidepressant drug, 1 will respond specifically because of the drug. Others will respond because of placebo-related mechanisms, and the rest will not respond. In this study, the response rate to antidepressants was 60% versus 11% to placebo. So overall, we know that 49% would respond to placebo, 40% would not improve, and 11% would respond because of the unique contribution of the antidepressant, which translates to an NNT of 9. This could also be relevant for addiction. Instead of placebo, an important issue is whether those who recover with no treatment, sometimes called natural recovery, we need to consider what proportion would recover without any intervention. There could be a variety of reasons for this, usually involving some sort of conscious choice to stop using drugs. Whatever the reason, natural recovery has been defined as recovery that occurs without treatment or support groups. So natural recovery may be an issue, and we can think back to the fourfold table that we looked at earlier. In order to evaluate treatment, we have to look at those who are not treated in order to make a comparison. There are 2 points to consider. First, natural recovery for both drug and alcohol disorders has been described as typical. One paper states that approximately 70% of people with alcohol use disorders improve without interventions. Secondly, natural recovery is not something that is usually considered when treating patients, as illustrated by the second quote. You might think that natural recovery is important. It would be considered in the Black Report, but there is no mention of it. And this is because, as we saw earlier, the Black Report considers addiction to be a chronic disease, and there is no role for choice in disease. In an earlier paper, I summarized research as follows. While drugs affect neural mechanisms, this does not translate into the abolition of psychological self-control. Stanton Peele goes further. He says the effect of conceptualizing addiction as a disease on treatment has been disastrous. The disease conception that addiction can only become progressively worse and never self-ameliorate is decisively wrong. So with these factors in mind, let's return to the number needed to treat and consider limitations, all of which are relevant to addiction. An NNT value tells you how many patients would benefit, but it doesn't tell you how much they may benefit or a number of other key factors. Some of these points are illustrated in this slide. How do we define treatment success? Is it a complete cure? Is it a 30% improvement? What was it compared to? A placebo? Another therapy that's known to be effective, or no treatment? How long did the results last? What was the length of the follow-up? How severe was the condition? So when we look at NNTs, we need to be aware of the context of the results and how they were generated. Let's consider 2 treatment and natural recovery scenarios. These situations are strikingly different, although in both situations, for every 9 people treated, 1 will recover. In scenario 1, the treatment response rate is 12% and the natural recovery rate is only 1%. The advantage for treatment is 11% and the NNT is 9. In scenario 2, treatment response rate is 99% and the natural recovery rate is 88%. The advantage for treatment is again 11%, an NNT of 9. In the first situation, there is almost no natural recovery, and medication is associated with a relatively large treatment gain. In the second situation, there is a much higher level of natural recovery, and medication is associated with a relatively small treatment gain. Yet the NNT is the same in both situations, so it's important to know not only what the unique contribution of the NNT is, the treatment, but also what the natural recovery rate is. This slide is taken from a 2010 Department of Education report called Specialist Drug and Alcohol Services for Young People, a cost-benefit analysis. It shows that there are many types of treatment available, and how do service providers and health professionals decide which service is the most appropriate? Is it possible to match patients to a specific type of treatment? I could go into much more detail here. For example, there are brief interventions, motivational interviewing, cognitive behavioral therapy, and so on. This is an issue beyond the scope of this presentation. But the important point is, where should the investment be? The Black Report talks of for every £1 spent on treatment, there is a saving of £4 in terms of health and criminal justice. The Black Report says that local authorities should commission a full range of evidence-based harm reduction and treatment services. But what is the evidence-based in this field? I don't have time to go into this, but given the limitations I have mentioned, do we have enough information to make an informed choice? And again, what about the thorny issue of natural recovery? The difficulty with evaluating addiction treatments is that outcomes are hard to measure. So there are not many examples in the evidence-based health literature, but here is one. To determine the effect of nicotine replacement therapy compared to placebo in aiding smoking cessation. Overall, NRT increased successful cessation rates from 10% with placebo to 17% with NRT. This results in an NNT of 15. An NNT of 15 means that 93% saw no benefit, while 7% were helped by NRT. The paper concludes that NRT appears to be a safe and effective option for current smokers who wish to quit. But as Peel points out, millions of people have quit without any treatment. And he also notes that surprisingly percentage of former heroin, cocaine and alcohol addicts who have quit on their own is even higher. So while there is some evidence to support NRT, we can't assess whether it leads to better outcomes in natural recovery, only compared to placebo. So let's look at a range of hypothetical scenarios. I have called scenario 1 the mainstream model, as this is the model implicit in the Black Report, namely that broadly speaking, treatment is effective, and I have assumed that 75% of people improve as a result of treatment, 25% show no change. For those not receiving treatment, 10% also get better, so that's natural recovery. These figures translate into an NNT of 1.5. So overall, a lot of people improve, 65% of people improve specifically due to treatment. So treatment is effective in this scenario, but not for everybody. I have called scenario 2 the epidemiological model, as there is high natural recovery. I have chosen this term because the epidemiological evidence seems to indicate that 50% is a reasonable figure for natural recovery, perhaps even on the low side. We can see that the treatment figures are the same as in the mainstream model, with 75% getting better. But because of high natural recovery, improvement as a result of treatment is much lower, with only 25%, with 75% not improving as a result of treatment. In scenario 3, we are looking at numbers needed to harm rather than numbers needed to treat. I've called this scenario the skeptical model because it is skeptical about treatment, at least some forms of treatment. The idea that people can actually get worse as a result of some forms of treatment is suggested by Stanton Peele, who writes, "Is it possible that the very act of turning oneself over to a treatment program is antagonistic to the feeling of self-efficacy necessary to succeed?" So in this scenario, treatment is less effective than in the previous one. Only 25% of people get better and 75% of people get worse. Natural recovery stays the same at 50%. So overall, in this scenario, 25% of people are worse as a result of treatment. In other words, for every 4 people treated, 1 will get worse. Now let's compare the 3 models that we've just looked at. And in these tables, I'm using the number of people in treatment in England as the denominators. And in 2021, there were 286,909 people in treatment at some point. So the table shows the 3 different models, which we've already talked about: the mainstream model, the epidemiological, and the skeptical model. And for each column, we have the percentage better due to treatment, the percentage better due to natural recovery, the percentage that don't change with treatment, and the percentage who get worse with treatment. Looking at the mainstream model, first of all, we can see that most people are getting better due to treatment. A small number are getting better due to natural recovery. Quite a lot are not changing, and we don't have any information on those who are getting worse. For the epidemiological model, most people are getting better due to natural recovery rather than treatment. Some are not improving as a result of treatment, and again, we don't have information on those getting worse. The skeptical model, potentially no people are improving as a result of treatment. Some are getting better due to natural recovery, some are not changing, but most are getting worse with treatment. So we can see how the number needed to treat information can be used to look at the effects of treatment under different scenarios and how these lead to very different conclusions. Going back to the Black report, my concern is that only the mainstream model is considered. We can also see the expenditure on treatment in 2021 before the recommended increase and how this translates to cost per person treated for the different models. In 2021, the treatment amount spent on treatment was £650 million. And in terms of the three models, the costs are clearly different per person treated, and this may have an impact on how we evaluate the cost effectiveness of treatment. Finally, this table does not consider the costs associated with different types of treatment, which can vary considerably. The Black report clearly implies that lack of treatment is leading to bad health outcomes, and that this could be reversed by additional investment. There's a clear implication of causality, that reduced treatment leads to an increase in drug-related deaths. But is there evidence to support this? We have to be very careful about assuming that correlation means causation. Deaths could have increased for many reasons other than a reduction in treatment. This slide shows that if we collect data for monthly ice cream sales and monthly shark attacks across the United States each year, we would find that the two variables are highly correlated. Although ice cream sales and shark attacks are highly correlated, one does not cause the other. The more likely explanation is that more people consume ice cream and get in the ocean when it's warmer outside, which explains why these two variables are so highly correlated. The distinction between correlation and causation seems to be straightforward, but it is easy to wrongly assume causation from correlation, especially when there is a complex interplay of variables. A good example of this concerns the potential association between cannabis use and psychosis. In a literature review reported in the Lancet Psychiatry, the authors write that the scientific literature on cannabis use and psychosis supports the hypothesis that both psychosis and cannabis use are more likely in individuals with a shared vulnerability to misuse of various substances use and various mental disorders. A strong tendency exists to accept cannabis use as a so-called component of psychosis, which then leads to the conclusion that it is imperative to reduce cannabis use. The authors say, although we understand this impulse is motivated by a concern for public health, we should not allow the consistency of these correlational findings to substitute for actual evidence of causality. In other words, the correlation between cannabis use and psychosis is not specific, either with regard to the chemicals found in cannabis or to psychosis as opposed to other disorders. So there are many pitfalls in evaluating treatment. As this paper says, evaluating the efficacy of a treatment without randomization is difficult and prone to errors. For example, if we evaluate the efficacy of a treatment program by comparing individuals who decide to attend a treatment program to those who decide not to attend, we are at risk of confounding. Specifically, the individuals who chose to attend the program who are non-randomly assigned to attend the program might differ from those who choose not to attend. These potential differences might therefore determine the outcome that occurs rather than a difference in the treatment that was received by the two groups. In addition, randomized controlled trials may also involve treatment delivery using highly skilled clinicians with intense supervision, which does not always reflect the realities of typical treatment deliveries. Randomized controlled trials with stringent inclusion and exclusion criteria may enhance internal validity by ensuring that the treatment is being tested among a homogeneous client population. However, this may affect the external validity. Finally, some issues to consider. First of all, we've looked at 3 different models. Do you agree with any of them? We've looked at the mainstream model, the epidemiological model, and the skeptical model, all of which have different assumptions about the effectiveness of treatment. Within that, things to consider are, is natural recovery a factor? Is addiction a chronic illness? And what forms of treatment are effective? The next issue is, do you agree with the recommendations of the Black Report to spend extra millions on prevention and treatment? Is this supported by the evidence? Is it likely to reduce the level of addiction and/or the harms caused by addiction? And finally, is addictive behaviour becoming a substitute for family and work bonds that are being swept away by globalisation and urbanisations? What are the implications of this? Is addiction a medical or an existential issue? So thank you for listening to this presentation, and I hope you have found it helpful.